Hello everyone, happy afternoon, a very good afternoon. I hope and I believe all of you are doing well. A quick nod everyone, am I audible and visible? Am I audible? Yes. Okay, that's great guys. Right. Good afternoon, everyone. I hope all of you are doing well and your preparation is going on in the full swing. So, with a small attempt from us at PrepLadder to help you in your final preparation to give you that extra edge, here we have the LRR series for the upcoming exam. This is definitely going to help you revise the most important topics for all the subjects by the respective educators. So, make sure you do not miss out on these topics and you revise them well before your exam. So today we are here to have LRR Radiology session, and session duration for today approximately right somewhere around 2 hours. Between 1.5 to 2 hours is what would be the target for today. And right, we shall share the PDF as well post session. Right, just give me a minute. Okay, how should we integrate an approach? What do you want to integrate, Anna? Yes, Dr. Devaki, yeah, long time. I think your name seems very familiar. Okay, so let's start discussing the topics for today, the LRR radiology topics. We shall do it, system-wise, the investigations and the anatomy, and then the various systems, then nuclear medicine, radiotherapy. That's how we will go. Okay. So let's start discussing the topics quickly, guys. Can you tell me investigation A and investigation B? What are these investigations here? Very, very important. I'm sorry. Yeah. Tell me, what is investigation A and what is investigation B here? Correct. Absolutely right. A is CT and B is MRI. A is CT and B is MRI. Very important when you have to differentiate CT from MR, look at the bone. And if the bone is white, particularly look at this bone cortex. Okay. So the inner part of the bone might appear black because the bone marrow might be fatty, appears black on CT. But the cortex is white. If the bone cortex is white, it is CT. The bone is black here. This is going to be MRI. Is this clear with everyone? So white bone versus black bone is what helps you to identify whether this is CT or this is MRI. Okay, whether this is CT or this is MRI. Correct. Going to the next one, look at these images here. First of all, tell me this image here. Is this CT or is this MRI? This image here. Is this CT or is this MRI? This is the white skull bone that you are seeing. This entire thing that you are seeing is the white skull bone. So this is going to be CT. This one here, is it CT or is it MRI? Now, do not get confused by looking at the outermost covering is white. So you think that this is white bone and this is CT. This is not a CT. This is basically, what is this one here that you are seeing? This white area that you are seeing here is the white fat of the scalp. This is not the bone. The immediately surrounding this brain parenchyma, this area that you see, that is the black bone. Okay, that's the black bone there. So this is what is MRI. This is the black bone. So all these three images which you are seeing here, this is the black bone, this is the black bone, this is the black bone. All of these are MRI. Now in MRI, identifying the MR sequences T1, T2 and flare. What is the first thing that you look for when you have to identify the MRI sequence is look at the water content. Water content in the brain is CSF present in sulcal spaces, in ventricles, right? So look at these ventricles appearing white, the sulcal space containing CSF appearing white. So you can see that in this image, water is white and this is going to be T2. So remember World War II, WW2, water white on T2. In none of these T1 or flare, you are seeing that the water is white. Now what remains is it T1, is it flare? So then remember for T1, your first year subject anatomy, one is first anatomy is followed on T1. What do you mean by anatomy is followed? White matter appears white, gray matter appears gray. Now what is the white matter in the brain? This corpus callosum is a white matter. Internal capsule is a white matter. All this is the subcortical white matter. So you can see that white matter is appearing white on T1. White matter is appearing black on flare. So what is happening on flare is it is all black. The water also is black and the white matter also is black. Right? So quick tips on identifying the MRI sequences. T2 water white, T1 white matter white, and on flare it is all black. Okay, on flare it is all black. Is this clear with everyone? Okay, so T1, T2 and flare, the minimum sequences in MRI brain that you should know, and that is asked in the exam. Now look at these two images and now tell me image A and image B. What investigations are these? Both CT, both MR, one CT, one MR. What investigations are these? This is CT. This is also CT because you can see that both of them are having white bone. So what is the difference in between the two? What is the difference in between these two images? Give me a minute. Very good. Contrast and non-contrast. So look at this one. This is the aorta. This is the aorta. Right in front of the vertebra, you have the aorta. So this is the aorta which is appearing gray and this is the aorta which is appearing white. It is appearing white because of the contrast. Okay. This is appearing gray because this is non-contrast CT. This is appearing white because this is contrast enhanced CT. Right, so remember that this is a contrast enhanced CT and that is why the vessels appear white on contrast enhanced CT. That is how you identify. What contrast do we use in CT scan? What contrast do we use in CT scan? Correct. We use iodinated contrast, and how do we give that contrast? Right. So remember the contrast used is iodinated contrast and the contrast given is IV. Tell me what investigation should you do before giving IV contrast in a patient where you are doing contrast CT? What investigation is a must before giving iodinated contrast? KFT. Absolutely right. Correct. This is KFT. That means you need to check for serum creatinine is a must. You cannot give contrast without checking serum creatinine in a patient. Okay. And what is the need of doing this contrast scan? Why do you want to do contrast CT scan? Because look at the image here. The lesions are seen on contrast scan. So for any lesion anywhere, any mass, any tumor, any lesion, you have to do a contrast scan. Non-contrast CT is investigation of choice for, this is again a favorite for your exam. Non-contrast CT is enough for what pathologies? See, if something is already white on non-contrast CT, so there's no need of giving contrast because contrast basically is helping it make appear white. What is already white on non-contrast CT is calcification. So remember urinary tract calculi. Okay, so for example, very frequently asked in the exam, for ureteric stone, ureteric calculus, non-contrast CT is the investigation of choice. Acute hemorrhage is something else which is hyperdense, which is white on non-contrast CT. So calcification, acute hemorrhage. So let's say in a patient of head injury, the first investigation that you do is non-contrast CT. Okay, correct. Going on to the next one. So in what investigation do you have this Hounsfield units, Hounsfield scale ka concept? Chronic hemorrhage, it is MRI. Because with chronic hemorrhage, what happens is the blood is not white anymore, so you cannot see it on CT. It appears like any fluid, but it contains like hemosiderin, the hemoglobin degradation products that show the appearance on MRI. Hounsfield units USD में होता है, किस में होता है? Hounsfield units, Hounsfield scale is the concept which is in CT, right? It is based on the attenuation coefficient of that substance. So imagine this Hounsfield unit basically is like a number scale. Okay, the numerical scale that we have with water in the center, 0 HU value is for water. Whatever is less dense than water, that is fat and air, they have negative HU value. Whatever is more dense than water, right, they have positive HU value. So important points for HU value, very, very important. HU value 0, this is one of the recently asked question, is for water. What has a negative HU value? Fat and air, because they are less dense. Remember, fat is like oil, so it is less dense than water, not more dense. Out of fat and air, fat is going to have HU value of minus 50 to minus 100. Air is going to be like minus 1000, more negative. Okay? So water appears gray, fat and air appear dark, they appear black on CT. Right? Now look at this image here. This was asked in one of the recent NEET PG exam. Now this is a CT scan with the white bone. CT scan of the chest. These are the black lungs that you can see. And look at this mediastinal mass here. Can you tell me what is this mediastinal mass containing? What is this white in the mediastinal mass? What is it containing? Yes? Very good. The white is the calcification. So this is a mediastinal mass containing calcification. And what is this in the mediastinal mass? Having this dirty black appearance. It's not like jet black. Look at this jet black appearance. This is of air. Air is jet black. And what has this dirty black appearance? It is black, but not like jet black. This is going to be fat. Okay, this is fat. So this mediastinal mass is containing fat and calcification. Whenever you see fat and calcification both present in a mass, what is the diagnosis that you think of? So basically it's a mass which arises from all the 3 germ layers. It has various tissues. What is that? It is a teratoma. Okay, it's a mediastinal teratoma that you are seeing here. Similarly, ovarian teratoma, that also has calcification and fat both. So remember, teratoma has fat plus calcification. The question asked in the NEET PG exam was, in the image, HU was labeled as, let's say, minus 63. And they had asked the interpretation that what is this? This is fat containing mass. Okay, fat containing mass. Absolutely right. Going on to the next one, identify this MRI sequence. So in this MRI sequence where you see those black areas and the brain appears like different, it does not appear like normal T1, T2 flare. And you see those black areas, the veins appearing black. This is SWI, that is susceptibility weighted imaging, which is a good sequence basically to pick up hemorrhage. It also helps you to differentiate hemorrhage from calcification. You can differentiate in susceptibility weighted imaging, SWI MRI. Okay, these are not these are the various hemorrhages that you are seeing here. Remember, SWI MRI is your investigation of choice for hemorrhage, like in diffuse axonal injury. For acute infarct, it is not SWI. What is the most sensitive for acute infarct? Yes, Afzal, what is the most sensitive for acute infarct? For acute infarct, it is DWI, diffusion weighted imaging. Okay, this is SWI for hemorrhage, diffuse axonal injury. You see those hemorrhages like this, petechial hemorrhages. And in acute infarct, it is DWI, which is the most sensitive. Going to next one, look at these investigations, A, B, and C. What investigations are these? See, first look at this image B. You can see this metallic endoscope which is there. This is the common bile duct that you have there, right? So basically with the endoscope, with the bile duct that you are seeing there, this will become ERCP, endoscopic retrograde cholangiopancreaticogram. This is the same ERCP. The learning lesson here is, remember in fluoroscopy is basically a video x-ray where you give contrast x-ray. It's a dye study. The contrast or the dense things, they can appear black or they can appear white. Okay? So this applies to any fluoroscopy image. So both of these are ERCP. Remember, even the black one is ERCP. And this one where you are seeing CBD and pancreatic duct, but there is no endoscope here. This is going to be MRCP, which is done in MRI. So remember, in MRCP, there will be no endoscope that you will see. In ERCP, there's endoscope that's going to be present. What is the advantage of MRCP over ERCP? The advantage is MRCP is non-invasive. ERCP is an invasive procedure. MRCP is non-invasive. And therefore, it is the investigation of choice for biliary pathologies, for CBD. Correct. Plus, there is no radiation in MRCP because it is MRI. ERCP is a contrast X-ray. It does have radiation. No. So remember, MRCP में contrast की ज़रूरत नहीं है. We can do MRCP without contrast. Why? Because this water, this fluid in the bile duct, pancreatic duct, they can appear white on MRI even without contrast. What sequence of MRI? T2 weighted MRI, right? The fluid, the water appears white on T2 weighted MRI. So MRCP is basically a heavily T2 weighted image where this fluid appears white. Okay? Clear with everyone? Look at this. Asked so many times in the exam. What investigation is this? White bone that you can see here is CT. And the orange color that you can see here basically tells you this is PET CT. PET combined with CT. When you see a orange colored CT image, it is PET CT. Okay. So PET CT is where you are combining PET and CT images superimposed over each other. So this is an example of hybrid imaging or fusion imaging. You are combining the two images together. Okay. Out of PET and out of CT, which is the functional imaging? This question has also been asked in exam. Out of PET and CT, which is the functional imaging? PET is an example of functional imaging. Okay, PET is an example of functional imaging. So PET basically uses FDG, 18-FDG, fluoride with deoxyglucose. So basically it is based on what metabolism? Glucose metabolism. The FDG PET is based on glucose metabolism. These are also PYQs that have been asked in the exam. Does PET have radiation? CT scan we know is X-ray. It does have radiation. Does PET have radiation? Yes. Remember, it comes under nuclear medicine. You are using a radioisotope. Radiation is coming in there. Remember, in both of these, the radiation is present. हर न्यूक्लियर मेडिसिन वाले स्कैन में रेडिएशन होगा. What investigation is this? You can see this blood vessel, you can see this graph of the blood flow. So this is the ultrasound which is for blood flow. So basically this is called as Doppler. Okay, this is called as Doppler. So does Doppler have radiation? Does Doppler have radiation? Yes or no? Correct. Doppler is USG, right? It's ultrasound. So does it have radiation? No radiation. Please remember, ultrasound and MRI do not have radiation. Very, very important. X-ray, CT, fluoroscopy, they do have radiation. There's no radiation. It is ultrasound. Okay. So Doppler is generally the first investigation that you do for peripheral vascular disease, which are easily accessible, the peripheral vessels on ultrasound. Right, that's the first investigation that you do for DVT as well. Right, so peripheral vascular disease, DVT, the first investigation you do is Doppler. Okay, so look at the waveform. This waveform that you are seeing, this is called as triphasic waveform. Okay, forward, backward, and then forward. So when you see triphasic waveform, remember it is artery or vein. Triphasic waveform is the normal arterial waveform in the peripheral artery. If you look at the limb arteries, this is the waveform that you would see. Look at this common femoral vein waveform. It's only on one side of the baseline. Plus it shows changes based on the respiration ke saath it changes. So the veins show monophasic flow with respiratory phasicity. Okay. They show monophasic flow with respiratory phasicity. Right? Tell me, what investigation is this? What investigation is this one here? Is this a routine CT or there is something more to CT here? Yes? Is this a routine CT, non-contrast CT, contrast CT? There's something else. So someone has answered this. Very good, Sangareshwar. Right, correct, Afsal. This is basically your CT cisternogram. Okay, this is called as CT cisternogram. What are cisterns? Cisterns are the CSF containing spaces in the brain. So can you see the contrast in the CSF containing spaces here? Look at these sulcal spaces, CSF appearing white. Look at this ventricle wala appearing white. Okay. So CT cisternogram is done for, what do you do CT cisternogram for? CSF leak. Right? Anywhere you are suspecting CSF leak, for example, CSF rhinorrhea, we do CT cisternogram. So what do we do here is, we do the lumbar puncture, we put the contrast into the CSF space, subarachnoid space, we give head-low position to the patient, right, so that the CSF goes towards the head, and then you give prone position to the patient and you take a CT image. So if there is CSF rhinorrhea, you would be able to see that from what side this CSF is leaking out. The contrast in the CSF makes the CSF appear white, and that helps us to localize the leak. Okay, so this is the white CSF. So in CT cisternogram, remember, you would see the CSF appearing white. Is this clear with everyone? Yes. What other tests do you have for CSF rhinorrhea? You do have beta-2 transferrin test, right? So if there is discharge coming from the nose, you want to prove that this is CSF, you can do beta-2 transferrin test. But will it help you localize from where the CSF is coming? No. Right? So the advantage with CT cisternogram is it helps you localize the site of leak. Beta-2 transferrin will just tell you whether this is CSF or no CSF. Okay. Going to next one. This is one of the recent FMGE exam question. This image has been asked, and what investigation is this and what is it basically used for? Yes? What is this investigation? So when you have a black and white ultrasound like image and you see this round circle wala as a probe, this is telling you that this is EUS, endoscopic ultrasound. This is EUS, endoscopic ultrasound, where you would see this circular probe like this. So you have an endoscope and attached to that you have a USD probe, so which gives you the ultrasound image. And what is it basically used for? The advantage with endoscopic ultrasound is you are going straight into like the lumen, and from there you can see the wall very clearly. So it helps you, for example, let's say esophageal cancer, T staging. What do you mean by T staging? The depth of the tumor. Whether the tumor has gone till submucosa, muscle, what layer. It helps you look at that. Okay? Clear with everyone? Right. So basically it helps you in the local staging of esophageal cancer. It can also be done for periampullary mass. You can take the endoscope still beyond, right? Go into the stomach beyond that, and this periampullary area also you can visualize well on endoscopic ultrasound. Okay? Clear with everyone? Right. So that was about the most important investigations that are asked in the exam. Give me a quick thumbs up if this is clear with everyone. So we have quickly seen the most important investigation images, that are must know: CT versus MR, sequences, non-contrast CT, contrast CT, right? ERCP, MRCP. For heart, you have echocardiography, which is done. Transesophageal echocardiography is done for left atrium, which is the posterior most chamber. Okay, great. Let's go on to the next system, that is radio anatomy. Right, now look at this. This is also one of the recent FMGE exam question, identifying the tarsal bone. And suppose the question asked was, अच्छा ये वाली bone कौन सी है बताओ, which tarsal bone is this? Yes, Aju, because it has no radiation and it is non-invasive. So MRCP is preferred. Very good. This is navicular bone. Okay, this is navicular. So identifying the tarsal bones. Remember the first one here, this is the area of the heel that you are seeing here. So in the heel area, the bone that you have, this is, what is this one here? Calcaneum, right? The heel bone is the calcaneum. This bone here, which you are seeing, which is forming this ankle joint. What is this bone here? This is the talus. Okay, talus is what forms the ankle joint. So you have talus, calcaneum, and in front of the talus, you have this. Now shaped is navicular. Remember, now shape, boat shape is the navicular. So that is how you identify talus, navicular, and calcaneum. Okay, in the lateral view, at least these are the most important bones that you should know here. Okay. What is the osteochondritis of navicular called as? What disease? Kinbox, Kohlers. What is the name of the osteochondritis affecting navicular? Remember, navicular is rhyming with Kohler. Okay, so that is Kohler disease. Kohler is the osteochondritis of navicular. Going to next one, even this is a recent FMG exam question. Identify the various organs on CT abdomen. So remember that in the radiology images, your left is the patient's right and your right is the patient's left. So on the right side, what you have here is the liver. Okay, so this one is the liver here. This is on the left side. This is going to be spleen. Okay, so you have the liver, you have the spleen. And what is this one here? What structure is this which you are seeing here? Anyone? What is this one here? Very good. Absolutely right. This is stomach. Okay. This is stomach. How do I know this is stomach? This is to the left of the liver. And what are these black in the stomach that you can see? The jet black areas. These are the air, right? Air will be present in the GIT part, right? The gut part. So this is the air in the stomach. The gray is the fluid in the stomach. And if you see carefully, you can see this rugae in the stomach also, right? That wall of the stomach. So air is present, fluid is present, rugae is present. This is going to be stomach. Okay, that's going to be stomach. Look at this one here. What is this? What is this? You can see that this organ is having a lot of white appearance because it is concentrating the contrast. The contrast is excreted via the kidneys. This is the right kidney. This is the left kidney. This is the spleen. This is the liver. And what is this structure here? Going towards the spleen, right? This is going to be pancreas. Okay, what is this going to be? This is going to be pancreas, right? Clear with everyone? Few more structures here. Identify this and identify this. What is this just in front of the vertebra? This is aorta. And what is this to the right of the aorta? Right of the aorta is the vein, which is the IVC. What do we have in the stomach is the IVC. SVC in the chest. So this is aorta, IVC. And what do you have in front of IVC going to the liver, supplying the liver? This is going to be portal vein. Okay, this is the portal vein going to the liver. Is this clear with everyone? So portal vein, IVC and aorta. Going to the next one, very, very important in the CT chest, in the mediastinum, the vessels that you have, the three main vessels. 1, 2, 3. Remember from right to left. What comes from right to left is SAP. Remember, right to left comes the SAP. What does SAP stand for? Superior vena cava, ascending aorta, and pulmonary trunk. Right? So that is the arrangement there. Superior vena cava, ascending aorta, and pulmonary trunk. You can see the main pulmonary artery is dividing into the right pulmonary artery and the left pulmonary artery. What is 5 and what is 6? Look at this 5 and 6. They are jet black. That means they are containing air, right? Now, this is not trachea because trachea would be only one circle. These are two after the division of the trachea. So, this is going to be right bronchus. This is going to be left bronchus. Okay, so right bronchus and left bronchus. And what is this number 4? Right in front of the vertebra towards the left side. This is aorta. What aorta comes here? Just in front of vertebra, this is the descending aorta. Okay, descending aorta in the posterior mediastinum, right in front of the vertebra. So, anterior is ascending aorta, posterior is descending aorta. So, this is ascending, this is descending. Okay, clear with everyone? And what is this one here? What is this structure? Which is appearing like a arch. Okay. So this is arch of aorta. What is this structure? Jet black, again air containing, but it is one single circle. It is not divided yet. So this is trachea. Okay. And think logically and tell me what do you think will be this structure now? The pink one is what structure? What is the pink one there? Very good. So to the right of the aorta is going to be its vein, that is superior vena cava. And if you look at this image very carefully, just behind the trachea, you have a collapsed structure with just a small speck of air inside, right? And this is behind the trachea, you have esophagus. Okay, behind the trachea, you have esophagus there. Okay, so trachea aage, esophagus piche. And what is this structure here? What is this one? Is it rib? Is it scapula? Is it clavicle? What is it? So this one here is the rib cage that you can see, right? Those are the ribs there. And this is behind the rib cage. So what do we have behind the rib cage is the scapula. The bone behind the rib cage is scapula. This is not clavicle. See, clavicle इतना नीचे ये aorta के level पे, lungs के level पे नहीं आएगा. Clavicle is going to be higher up at the lung apex. Okay, this is behind the rib cage, posterior to the rib cage. This is going to be scapula. Okay. One of the INI-CET exam question. This is the arch of aorta that you are seeing here to the left of the trachea. And it is giving a branch which is going in front of the vertebra. Normally, you do not see any branch from the arch of aorta like this. So what is this branch coming from the arch of aorta going in front of the vertebra? What is this one? This is called as ARSA, aberrant right subclavian artery. Right? It comes from the arch of aorta, goes in front of the vertebra behind the esophagus, and it goes to the right side. Okay, so that is aberrant right subclavian artery. Look at this one. If you are seeing a vessel in front of the vertebra in the chest like this, this is ARSA. And these are the other three branches from the arch of aorta. Okay, the last branch here is the right subclavian artery. Is this clear with everyone? What does ARSA cause? Because it compresses the esophagus. Dysphagia. What is that dysphagia called as? Dysphagia lusoria. Okay, that is called as dysphagia lusoria. Going to next one, very, very important, identifying the heart chambers. So this anterior bone is sternum. This is vertebra. This is the heart that you are seeing with the four chambers. So the anterior most chamber of the heart that you have just behind the sternum. Okay, the anterior most chamber of the heart just behind the sternum is what chamber? That is the right ventricle. So remember, right ventricle is anterior most. Opposite of that, what is the opposite of right ventricle? Right ka ulta left, ventricle ka ulta atrium. So the posterior most chamber is going to be left atrium. Okay? Now this is the axis of the heart. This is the midline of the heart. To your left side are basically right-sided chambers. To your right side are left-sided chambers. So if this is right ventricle, this is right atrium. This is left atrium. This is left ventricle. Okay, this is how you identify the heart chambers. Very, very important. For which chamber of the heart do we use transesophageal echocardiography? Transesophageal echocardiography is done for what chamber? So this is where the esophagus comes. Okay? So through the esophagus, you can see the left atrium. So remember, it is done for left atrium. So for example, when you want to see left atrial clot in a patient of atrial fibrillation, you do transesophageal echo. Okay, you do. Other way round, if I can ask, which chamber enlargement? The screen is gone. Just give me a minute. Am I audible and visible, everyone? Yes, okay, that's great. Right, sorry for that interruption, but thankfully we are back. So we were discussing about other way around. If I ask that, which chamber enlargement will cause esophageal compression? So remember, it is left atrial enlargement. It is left atrial enlargement which will cause esophageal compression. Okay, left atrial enlargement will cause esophageal compression. Is this clear with everyone? Yes, correct. Stab injury jab hoga, right ventricle affect hoga because it is anterior most. Okay. Going to next one, very, very important, identifying the ribs, anterior, posterior, and counting the ribs on a chest x-ray. One of the recent questions for all the exams, right? Now, how do you identify the anterior and posterior end of the rib? Now, understand that a rib, imagine a rib coming from behind attached to vertebra and it comes in the front. The anterior end of the rib is oblique. Okay? The posterior end of the rib is horizontal. So what do you have is, and the posterior end of the rib you can see is going, the bony part is going till the vertebra in the midline. The anterior ends of the rib, they are attached to the costal cartilage, right? So that costal cartilage we cannot see on x-ray until and unless it is calcified. So the end of the rib that you can see is going till the midline is the posterior end, and the end you will see which is oblique, right? And you cannot trace it here till the midline. Suddenly it starts fading here. This is the anterior end. So what are you seeing here? These ones that you are seeing, these are the anterior ends of the ribs, and the ones which you can see more clearly, these are the posterior ends of the ribs. Okay, so I hope this is first clear ki anterior hai ki posterior, because this has been asked in the exam. Then coming to counting of the rib. Okay, so when you have to start counting the rib, what you start counting is with the first rib anterior end, because it is more broader, right? The first rib is more broader and you can see it here. This is the first rib, this is posterior end, this is second rib, and this is posterior end, third rib, posterior end. Now a common mistake that is done here is, look at this first rib posterior and the second rib posterior, they are very, very close together. Okay, so here we can tend to make a mistake, and that is why start counting from the anterior end. First और second close है, फिर उसके बाद अच्छी gap दिखेगी. Third, fourth, fifth, sixth, seventh posterior rib is what you can see here. Anterior ribs, first anterior, second anterior, third, fourth, fifth, sixth is what you can see here. Is this clear with everyone? Right? Okay, so look at this one. This is the first rib posterior end. This is the second rib posterior end. So here also you will see here that this is the first rib posterior end. This is the second rib. This is the third rib. This is the fourth rib that you are seeing here. What additional thing that you can see here on the right side is there is one more rib that you can see here. This is the cervical rib. Okay, one more additional rib that you can see coming like straight downwards. This is the cervical rib that you are seeing on the right side. Is this clear with everyone? So if I have to count the ribs here, look at the anterior end. ये है first anterior end. यहाँ पे आएगा second anterior, third, fourth, fifth, sixth. Okay, these are the anterior ends that you are seeing. Posterior में, this is the first posterior, this is the second posterior, third, fourth posterior, fifth, sixth, seventh, eighth, ninth, 10th. Okay, that is what I'm seeing here, and then you have the 11th one here that you are seeing. ठीक है, समझ में आया? काउंटिंग ऑफ द रिब एंड द एंटीरियर एंड पोस्टीरियर. एंटीरियर is oblique, does not go till the midline. Posterior is more horizontal and it is seen going till the midline and it is more horizontal. Okay, so this is the rib counting that you see, and this is the cervical rib that you are seeing here. Going to the next one, identify the structures here. Of course, this is beneficial for NEET as well. This is what investigation? पहले तो ये बताओ, CT है, MRI है, क्या है? This is the black bone cortex. This is MRI. Please do not go by the bone marrow. Look at the bone cortex. You can see this ligaments very well on the MRI. What is this ligament here? Going to the anterior side of the tibia. This is going to be ACL, and this one is going to be PCL, right? The two crossing. The one on the posterior end of tibia, that is posterior cruciate ligament, anterior cruciate ligament. And what are these triangular structures? This is the meniscus. Okay, the triangular one is the meniscus. The bow tie appearance is for the meniscus. Okay, Coming to MRI brain में सबसे पहले ये बताओ, ये FMG में पूछा गया है. What is the structure that you are seeing here? Is this midbrain, pons, medulla, or is it something else? So the classical appearance that you have here, which looks like this heart shape or Mickey Mouse shape, remember Mickey Mouse shape or heart shape, MIMI, is midbrain. Okay, right in the midline you have the brainstem. So this is going to be midbrain. This is the sagittal MRI brain. This is the brainstem. Number one here is midbrain, then pons, and then medulla. This structure here that you are seeing, this is cerebellum. What do you have between pons and cerebellum? Number 5, the triangular structure. This is the fourth ventricle there. Right in front of midbrain, this circular structure small, MB के आगे आता है MB, that is mammillary body. This one here is the pituitary gland with the stalk of the pituitary gland in the sella turcica. And number 8, black air containing, is the sphenoid sinus. Close to the pituitary is the sphenoid sinus. This white matter tract here, this is the corpus callosum. And below that, this white matter tract is fornix. Okay, this is fornix, very, very important. This area here is the area of the lateral ventricle. This one here, the round structure related to the third ventricle, that is going to be thalamus. Okay, that's going to be thalamus. Is this clear with everyone? Empty cella nahi hai ye. Here you can see the pituitary in the cella. Empty cella means where you would see that the cella is not containing pituitary, it is compressed by the CSF. It's all water containing. So that happens in cases of like raised ICT वगैरह में CSF जाएगा and that will give the empty cella sign. Right? Clear with everyone? So you have the bent genu, body, and the splenium. The posterior part is called as the splenium of the corpus callosum. Going to next one, can you tell me what is this air cell called as? Is this agar nasi? Is this Haller cell? Or is this Onodi cell? What cell is this? So the cell that you see, infraorbital air cell. This is beneath the orbit. This is the eye, the orbit ka structure. Infraorbital air cell is called as Haller cell. Right? We have discussed the details of that in our RR videos as well, the various variations in PNS. This is Haller cell, not the Onodi cell. Onodi cell, remember ON is related to optic nerve. Okay, this is not this is not optic nerve related, this is infraorbital Haller cell. So that was about important anatomy images, guys, the most important ones that you should definitely know. So we are done with investigations and anatomy. Next one we have is emergency radiology. Give me a quick thumbs up if this is clear with everyone. Yes, so that we can move on to the next section. Great. Happy to see that. Right, going to emergency radiology, another important segment in radiology where you are generally asked questions. So CT brain, image A and image B. What is it showing? This is a hypodensity or a hyperdensity. See, this is appearing dark. Okay. This is dark as compared to the normal surrounding brain parenchyma. Dark means less, hypodense. Hypodensity, right? This is a hypodensity and this is white, more dense. White is more dense. More matlab hyper density, right? So a very well defined hypodensity like this in the brain represents infarct and the hyperdensity represents acute hemorrhage, right? So please remember that infarct is hypodense and acute hemorrhage is hyperdense. Because in infarct there is edema which comes in, decreases the density. Acute hemorrhage has RBC cell present, it increases the density. So infarct and acute hemorrhage. Clear with everyone? In both of these, the first investigation that you do is non-contrast CT. Emergency brain ka kuch hai, first investigation is non-contrast CT. Okay. Now look at the various hemorrhages here. The one which is biconvex shape is EDH. Right? The one which is crescent shape, sickle shape. Remember sickle shape, S for S is SDH. And the one which is showing the blood in the CSF space, sulcal spaces, cisterns, you are seeing the CSF is replaced by blood. Okay? So remember, this is going to be subarachnoid hemorrhage because CSF is present in subarachnoid. Nahi, hypo wala chronic nahi hai. Even acute infarct will be hypodense. Chronic infarct will be even more hypodense like CSF. This is subarachnoid hemorrhage. Subarachnoid hemorrhage presents with thunderclap headache. A very severe headache, thunderclap headache. Right? Clear with everyone? So EDH, SDH and SAH. EDH is because of rupture of middle meningeal artery. This is because of rupture of cortical bridging veins. And this is because of rupture of Berry aneurysm in the circle of Willis. Okay, Berry aneurysm. Going to next one, in a patient of trauma, if you see those tiny petechial hemorrhages, those black areas on SWI MRI, this is a patient of diffuse axonal injury. Okay, this is a patient of diffuse axonal injury. Is this nahi? White matlab hyperdense. Okay. So classical history in diffuse axonal injury will be a patient who has had a history of trauma and the GCS is poor, the GCS is worsening, right? And you do CT scan, most of the cases the CT appears normal and therefore the investigation that helps here is SWI MRI, which helps you pick up these petechial tiny hemorrhages. The black areas are the tiny hemorrhages. Going to next one of the recent exam question. What is this in the cephalic cavity? What is this jet black? What is this jet black here? This is air. Air in the cephalic cavity. So this becomes your pneumocephalus. Okay, tension pneumocephalus, which appears like this mountain wala sign. So what is this sign called as? Mount Fuji sign. Okay, what is this sign called as? Mount Fuji sign is seen in tension pneumocephalus, not pneumoperitoneum or pneumothorax. Next one, this is FAST that has been done in a patient of trauma, focused assessment sonography for trauma. Is this FAST positive or is this FAST negative? How do you identify it is FAST positive or FAST negative? Basically looking at the free fluid. And how does free fluid appear on USG? Free fluid on USG is black. So you can see this black color fluid which has accumulated between liver and the kidney. So this is FAST positive. Okay, this is FAST positive. That tells you that there is some bleeding going on from somewhere and that is why the fluid has accumulated. So what do you do if the FAST is positive? Depends on whether the patient is stable or unstable. If the patient is stable, you do detailed evaluation with CECT. If the patient is unstable, you do not have time, you go for surgery, right? Exploratory laparotomy. EFAST includes thorax, right? To evaluate pneumothorax. So remember, if the thoracic area is also included apart from these four areas. So these four areas is FAST plus the thoracic becomes the EFAST. Right? So if the pleural cavity is also included, it becomes EFAST. Now, what is the sign in pneumothorax that you see in ultrasound? EFAST jab karte M mode. Remember this sign, the flat lines in the lower half of the image. This is the barcode sign. or the stratosphere sign, which is seen in pneumothorax. Normal lung shows this granular appearance, the seashore appearance, but pneumothorax shows this barcode or stratosphere sign. So focus on this lower half of the image, not on the upper half, to decide कि ये barcode है कि ये seashore है. So normal people go to seashore, pneumothorax patients are barred from going to seashore. So they have barcode. Okay. Next one, very, very important. What are you seeing here? What is the first image, the left image showing? Look at this. The white line that you are seeing is the diaphragm. The white line that you are seeing is the diaphragm. And this is significant air under diaphragm that you are seeing here. Okay. So this is air under diaphragm, which is pneumoperitoneum. Okay. Pneumoperitoneum, which is, what is a common cause for pneumoperitoneum? The bowel perforation, the stomach perforation. So generally they give you in the history of peptic ulcer wala patient. Peptic ulcer का है patient और अभी acute pain हुआ है. You think of peptic ulcer which has perforated. So this is pneumoperitoneum. And what is this sign in pneumoperitoneum that you are seeing here? This lucency over the entire abdomen coming like a football. This is called as football sign. So remember, pneumoperitoneum has this football sign. Plus you have this ligament which is seen very clear. This is the falciform ligament sign. Okay, the falciform ligament sign, football sign is what we can see in pneumoperitoneum. Okay, clear with everyone? Next one, coin in trachea versus coin in esophagus. Look at the AP view. Look at the AP view, right? Looking from the front. If in the AP view the coin is circle, it is esophagus. If it is like this vertical slit like, it is trachea. That's the easy way to identify. So circle wala is esophagus and slit wala is trachea. Opposite in the lateral view, opposite in the lateral view. Whatever is circle on AP is slit on lateral. What is slit on AP is circle on lateral. Okay. So this is how you identify coin in esophagus, coin in trachea. And what is this one? What are you seeing here? Again, recent favorite for the exam. What is this one? You can see the double ring appearance here. Right? What can you see here is the double ring appearance. So what does that double ring indicate? The double ring appearance basically indicates this is not just a coin. Okay, this is button battery. Okay, this is a button battery and not just coin. Now, the difference in the management of coin in esophagus versus the button battery is button battery has the corrosive, the alkaline fluid present in it. So this needs removal, immediate removal, even if the patient is asymptomatic, because that fluid will cause the esophageal perforation. So this needs removal. While if it's just a coin in the esophagus asymptomatic, you can wait and watch, but not for button battery. Okay, not for button battery. Done? Yes, that's another favorite, has been asked in the exam many times. So this was about emergency radiology, the most important images. We shall see pneumothorax ahead. So if you're waiting for pneumothorax in thoracic radiology, we'll see that. Right. Without me asking, there has to be a thumbs up when we are finishing every section so that I know that everybody is here, awake, listening, and you have understood everything. Done? अफजल इज लाइक अब आएगा मजा, तो अभी तक मजा नहीं आ रहा था. Or is it like अब आएगा और मजा? ठीक है. So going on with thoracic radiology. Recent exam question. Tell me what sign is this and where do we see this? What sign is this and where do you see this sign? So this is the black air appearing like a crescent. Logically, you can see that. Okay? Right. So what is this sign called as? This is called as air crescent sign. Crescent matlab like the moon. So remember, this is also called as monad sign. And where do you see this? This is seen in aspergilloma. That's basically a fungal ball. So the history that the question generally gives is this is a patient of TB. So already there's a cavity in the lung and the fungal ball takes a chance and comes and sits in that cavity. So what happens is ये cavity है और उसके अंदर there comes this fungal ball. So what happens? The remaining air becomes like a crescent. So that is aspergilloma, which gives the air crescent sign. Okay, look at this air crescent here. Air crescent sign, aspergilloma fungal ball. Next one. What is this sign here? The lung has become white and through that you can see this black bronchi. Okay, you can see this black bronchi going through the lung. So this is, and what are these bronchi containing? Black. So they are containing air. So what is this sign here? This is air bronchogram sign. Okay, now this is air bronchogram. This is not tramp track. Tramp track is going to be the bronchi, right? Dilated bronchi in bronchiectasis. This is in the white lung. You are seeing the black line, that is air bronchogram sign. Okay, what does the air bronchogram sign indicate? It indicates it's an intraparenchymal pathology where the lung has become white, like in consolidation. When I say consolidation, any cause of lung solidification, like it could be pneumonia, it could be pulmonary edema, pulmonary hemorrhage, right? Any cause will give this air bronchogram sign. Will you see this air bronchogram sign in pleural effusion? Is pleural effusion in the lung? No, it's outside the lung. So please remember, it is not seen in pleural effusion or even in mediastinal mass because it is outside the lung. The lung has to become white to see those black bronchi very clear. So it is only the lung wala pathology which will give this air bronchogram, not the pleural effusion or mediastinal mass. Also remember that has been asked. What is this one here, guys? What are you seeing here? Look at this bilateral, almost symmetrical opacity in the lung, which gives this bat wing appearance. So this is the bat wing appearance of pulmonary edema. Okay, bat wing appearance of pulmonary edema. Correct. Has been asked in recent exam. Coming to the pleural pathologies, hydropneumothorax, pleural effusion and pneumothorax. Look at the image A, B and C. Hydropneumothorax, pleural effusion and pneumothorax. What are you seeing here? First one, the blunting of the angle with this meniscus shape or the curve that you see. Remember, the curve is called as the Ellis curve, is going to be pleural effusion. Pleural effusion ka water level is never like flat horizontal. It has a curve. Okay, when you see a horizontal line with the blunting of the angle, then it is hydropneumothorax. HPTX is hydropneumothorax. So remember, H for H, hydropneumothorax has a horizontal level. Pleural effusion has a curve. Hydropneumo means water and air both together. Wherever there is air fluid level, air and fluid together, the level is horizontal. And the next one here, this white is the collapsed lung and surrounding that is the entire pneumothorax. Okay, so this is not a normal x-ray. This is the collapsed lung with the surrounding black area that you are seeing. That is the pneumothorax. Remember, pneumo is air. It will appear black, right? Even the lung appears black. So how do you differentiate this is normal lung or pneumothorax? It appears more jet black because it does not have the vascular markings. Normal lung has these white vascular markings. So remember, pneumothorax will be black without any vascular markings. It is going to be black without any vascular markings. Pneumothorax, if it causes tracheal shift, will cause tracheal shift to what side? So when do we use the term tension pneumothorax? Tension pneumothorax is a clinical diagnosis. If the patient is unstable, the blood pressure is low, then you call it, and radiologically, the sign of tension pneumothorax is mediastinal shift. So if the patient clinically is unstable, then you call it tension pneumothorax and it needs immediate management, that is the needle puncture. Okay? Right. So if at all it causes tracheal shift, mediastinal shift, that will be to opposite side because it needs space. So it will shift the structures to opposite side. Okay. Going to next one, the sign, that is the Silhouette sign. Depending on what border is obscured by a pathology, you identify what lobar pathology it is. So if the right heart border is obscured by a pathology, it is the pathology in right middle lobe. If the left heart border is obscured by a pathology, it is we do not have left middle lobe. Corresponding to that is lingula. So right heart border gone, it is going to be right middle lobe, left heart border is lingula. Okay. What lobar pathology is this? This is FMGE PYQ. On a lateral chest x-ray, you are seeing this opacity, which is like this triangular wedge shape overlying the heart. Classically, when you see on a lateral x-ray, this triangular opacity overlying the heart, this is nothing but right middle lobe ka pathology. This is right middle lobe collapse. Okay, because the two lines of that triangle or wedge represent the two fissures of the right side. On the right side, you have the horizontal fissure and the oblique fissure. In between these two fissures lies the right middle lobe. So this is going to be right middle lobe pathology. Okay. Next one, classical again. Round opacities in the hilum, bilateral hilum. This is bilateral hilar lymphadenopathy. Whenever you have bilateral hilar lymphadenopathy, always think of sarcoidosis. Very important. Whenever you see bilateral hilar lymph nodes, always think of sarcoidosis. Very important. Right? Findings for lung abscess in a chest x-ray. Lung abscess will have air fluid level. You'll see a round lesion in the lung with air fluid level in a lung abscess. Okay, coming to the various heart appearances in congenital heart disease. First one here, this is a boot shape heart. Remember boot, इसको उल्टा करेंगे TO बनेगा. This is seen in TOF, tetralogy of Fallot. Why do you see boot shape in TOF only? Because TOF has RVH, right ventricular hypertrophy, takes the apex up. This is the figure of 8, right figure of 8, also called as snowman heart, which is seen in TAPVC. What type of TAPVC? Supracardiac TAPVC. Okay, remember snow falls from supra. This is the egg on string or egg on side appearance. Remember egg on string or egg on side, which is seen in transposition of great arteries. And this is the significant right atrial enlargement with the box shape heart. Remember B for B. It is seen in Epstein's anomaly, which is the teratogenic effect seen with lithium. Box shape heart, Epstein's anomaly, lithium. Okay. Okay, tell me the diagnosis here, guys. Look at the image and tell me what do you think is abnormal here in this image. If you want, I'll put an arrow here. Okay? But what are you seeing here? Very good. Doctor Psych Mind Scan. Correct. Archit. So this is the white line surrounding the heart. Right? You can see this areas which are white surrounding the heart. So basically this is showing the pericardium which has calcification. White is calcification. So this is pericardial calcification, which is a finding that you see in constrictive pericarditis. Okay. So this is going to be constrictive pericarditis that you are seeing here. What pattern do you see in JVP? The M pattern, right? The Y descent is prominent. The X descent is also present. The Y is also present, but the Y is more steep. Okay, so remember this is constrictive pericarditis. Next one, what are you seeing here? The rounded lucencies in the thorax with the diaphragm not seen here. Congenital diaphragmatic hernia. This one here, where you see again these rounded areas in the chest. But remember here in this patient, you can see the diaphragm well. So this is not your congenital diaphragmatic hernia. This is another pathology which is called as CPAM, congenital pulmonary airway malformation, previously called as CCAM, cystic adenoid malformation. Right, here you will have history of recurrent respiratory infections. ठीक है, रिकरेंट रेस्पिरेटरी इन्फेक्शंस का हिस्ट्री होगा. यहाँ पे हिस्ट्री होगा ऑफ रेस्पिरेटरी डिस्ट्रेस इन द न्यूबॉर्न. राइट, सो द क्लिनिकल हिस्ट्री इज वेरी इंपॉर्टेंट फॉर रेडियोलॉजी क्वेश्चंस. सो दिस सी कैम, यू कैन सी दिस एयरवे मालफॉर्मेशन. तो ये वाला ऐसा सिस्टिक अपीयरेंस दिखेगा इन द लंग इटसेल्फ. ओके, इन द लंग इटसेल्फ. So that was about the most important images in thoracic radiology. Going on to abdominal radiology, what are you supposed to do? Morgagni hernia will it's there on the right side, right anterior, and if this is the heart, Morgagni hernia generally comes here in the right cardiophrenic angle. You will see one large opacity like thing. Okay. कोई break नहीं मिलेगा. There is no provision of break here. Great. Going on to the next one, that is abdominal radiology. Very favorite for the exam. What is this? Dilated esophagus with the bird beak appearance, the narrowing of the LES. This is the bird beak appearance, narrowing of the LES. This is achalasia cardia. Dysphagia is more to solids or liquids? Question is incorrect batao. Correct nahi. Do not do that mistake. Okay, futuristic surgeon. Dysphagia to solids is going to be incorrect. Remember, in achalasia, the contracted LES, when the patient eats solid food with its weight and pressure, this will open. So the dysphagia to solids is less. Liquids ka dysphagia is more than solids ka dysphagia. Okay. Gold standard investigation is manometry. Okay. We use Chicago classification and Haller's myotomy. So remember, this is about achalasia. What is the diagnosis here in this image? How many bubbles? 1, 2, 3. Triple bubble appearance is seen in jejunal atresia. ठीक है, pyloric atresia, फिर duodenal atresia, फिर jejunal atresia, single bubble, double bubble, triple bubble. So triple is jejunum, double bubble is going to be duodenal atresia, triple bubble is going to be jejunal atresia. Duodenal atresia, D for D, remember, is associated with Down syndrome. So triple bubble has been asked. हमेशा double bubble पूछते थे, तो अभी फिर recently triple bubble पूछ लिया था. Okay. What are you seeing in this image? Ultrasound. Stomach, pylorus coming like this. Look at the elongated pylorus. Look at the thickened wall of the pylorus. Okay? So this is the pylorus, which is elongated and thickened wall. This is the transverse section for that pylorus. What appearance is it showing? Double circle appearance. This is called as target sign or the donut appearance. This is CHPS, congenital hypertrophic pyloric stenosis. Okay? What is the investigation of choice? Very frequently asked question. It is ultrasound. Why? Because in ultrasound, you want to measure the length of the pylorus and the thickness of the muscle wall. Thickness more than 4 mm, length more than 16 mm. Remember 4 and 4 square. Thickness more than 4, length more than 16. Okay, so this is CHPS. What is this one? Classical, where you see this coffee bean appearance. Coffee bean sign. Coffee bean is hallmark of sigmoid volvulus. Okay, this is sigmoid volvulus. Coffee bean appearance. Remember, there are no hostrations in sigmoid volvulus. Hostrations are absent. What are you seeing here? Look at the barium minima. What is the sign on barium minima? The barium is stopping like a claw. Okay. So this is the claw sign. Okay. This is the claw sign of intersusception. And what do you see in CT ultrasound and intersusception? Inner bowel, outer bowel. So inner bowel, outer bowel appearance in intersusception. That again is the target sign or donut sign. What is the other sign in intersusception and barium minima? What is the other sign? One is claw sign. Other sign is coiled spring sign. Even this has been asked. Okay? So in between the two bowel loops, the barium can go like a coiled spring. So coiled spring sign, claw sign is what you have in intersusception. Classical history is going to be history of red currant jelly stools. Okay, classical history is going to be history of red currant jelly stools. Is this clear with everyone? Yes? Correct. Going to next one, gallbladder pathology. सबसे पहले ये वाली देख लो. The most easy and the most important one, where you see this posterior acoustic shadowing. Posterior acoustic shadowing is present. This is going to be stone. Okay, this is a gallstone. So what is the investigation of choice for gallstone? It is ultrasound. What is for urinary stone? Non-contrast CD. Okay, posterior acoustic shadowing is present. This is gallstone. What is this one here? An echogenic thing present in the gallbladder, right? But it is not showing any shadowing and it is immobile. No shadow present. It is immobile. You ask the patient to turn to the other side. This is not going to move. This is going to be gallbladder polyp. Okay, this is a polyp. That's how you differentiate. Calculus agar hoga, patient ko turn karoge, to calculus ka position will also change. But this is not mobile. Okay, stone is going to be mobile. This is non-mobile. And what is this normal variant in the gallbladder ka appearance that you are seeing? Like the fundus is folding like this, like a cap. This is called as Phrygian cap. Okay, Phrygian cap, which is the normal variant. Okay, Phrygian cap, which is a normal variant. What is the diagnosis here? Remember, in liver lesions is where you do this triple phase CT, arterial, portal and delayed phase. So liver lesion के लिए करते हैं हम triple phase CT is done for liver lesions. And if you see that a liver lesion on arterial phase itself, it is becoming wide. It is enhancing on arterial phase itself. Early arterial enhancement is a feature of what liver lesion? It is HCC. Why it is enhancing on the arterial phase, early enhancement only? Because it is supplied by hepatic artery. HCC is supplied by hepatic artery. Normal liver is supplied predominantly by portal vein. So hepatic artery wala pehle enhance hoga. So if you see early arterial enhancement, remember it is suggestive of HCC and it shows early washout of contrast as well. Okay, it shows early washout of contrast as well. Next one, what is this? in the liver? Is it a cyst or is it something else? Yes. This is not a cyst. Why this is not a cyst? Because cyst by definition has a very thin wall which you might not be able to see as well. But look at this lesion. This lesion has a wall which is a more thick wall. It is not like a very thin wall. Okay. So a solitary hypodense lesion in the liver with a thick wall like this, you think of liver abscess. Which liver abscess is generally solitary? The amoebic liver abscess. Pyogenic one are multiple. And what history do you have in amoebic liver abscess? First is the amoebiasis. So there's going to be history of the bowel affected. Dysentery का history होगा. फिर उसके बाद ये amoebic liver abscess होगा. So when you have history of dysentery followed by liver lesion, anchovy sauce appearance, it is amoebic liver abscess. And if you see a calcified lesion in the liver like this, calcified lesion in liver like this, think of hydatid cyst. Okay? Classical sign in hydatid cyst that you are seeing here, you can see this membrane floating inside the cyst. This is the water lily sign. Okay, that's a water lily sign of hydatid cyst. Another appearance, a mother cyst with multiple daughter cysts inside. It can give this cyst within cyst appearance or the honeycomb appearance. So water lily sign is very, very important and frequently asked. Hydatid cyst. Correct. What is this one here in this image has been asked in one of the recent exams. If you look at the X-ray, you can see this wide calcification in this area. So what is this area is for what organ? Pancreas. So you can see pancreatic calcification. Whenever you see pancreatic calcification, what do you think of? Remember C for C, pancreatic calcification. Think of chronic pancreatitis. Okay, that is chronic pancreatitis. So similarly in CT, you can see this calcification in the pancreas, that is chronic pancreatitis. And look at this duct in the pancreas. How is the duct in chronic pancreatitis? It is dilated pancreatic duct. In chronic pancreatitis with the fibrosis, right, the atrophy of the pancreas happens and the duct gets dilated because there's no pancreatic mass to compress on the duct. So it gets dilated. So pancreatic calcification with dilated pancreatic duct, remember it is chronic pancreatitis. Versus what are you seeing here? Gray is the fluid and surrounding wall is seen here. In a patient of pancreatitis, this represents pseudocyst, has been asked twice in the exam. Okay, that is pseudocyst. So what do you see in acute pancreatitis? How is the size of the pancreas? The pancreas in acute pancreatitis. Remember, any acute inflammation, the edema comes in and the organ becomes enlarged in size. So when you have bulky pancreas which is present, surrounding fluid present, gray fluid present, you are thinking of the diagnosis of acute pancreatitis. Okay, bulky pancreas with fluid, you know that edema comes in, fluid comes in. So those are going to be representative of acute pancreatitis, has been asked in NEET PG exam. That is bulky pancreas is acute pancreatitis. Okay. Next one. What are you seeing this renal lesion is containing? What is this in the renal lesion that you are seeing? Again, remember that is the dirty black appearance. Dirty black is the fat. So fat containing lesion in the kidney is renal angiomyolipoma. Okay, angiomyolipoma. And where do you have bilateral renal angiomyolipoma common in what condition? It is tuberous sclerosis. Okay, tuberous sclerosis में ये bilateral renal angiomyolipoma commoner. How does this angiomyolipoma appear on T1 weighted? Remember, it is appearing white. Why? Because T1 white, remember, fat is white on T1. White hyper intense on T1 is fat. Okay, fat is white on T1. Clear with everyone? Correct. This is a gray colored fluid containing lesion. You can hardly see any wall there. So this is renal cyst. Okay, this is renal cyst. What is the name of the classification that we use for renal cyst? It is Bosniak classification. Okay, Bosniak classification for renal cyst on CT. And this one here is a mass in the right kidney. This is the kidney here and there's a mass which is enhancing, showing necrotic areas. You have, let's say, history of hematuria. This is going to be renal cell carcinoma. It is an enhancing mass which is present. History of hematuria, right, can be present here. This is, so cyst is something which does not enhance because it just contains water. Carcinoma contains tumor, right? A solid tumor. So that enhances. So renal cyst is non-enhancing while RCC is going to be enhancing. Okay. Coming to the renal calcification, you can see this calcification is taking the shape of the pelvis and the calyces. What is this called as? This calcification is called as staghorn appearance. Okay, so this is staghorn calculus. This calcification, which is more like this triangular appearance with the lucent areas in between, this is called as medullary nephrocalcinosis. This is medullary nephrocalcinosis, which you can see in what endocrine condition? Where there is hypercalcemia, the calcium increases, goes in the kidney. So you can see it in hyperparathyroidism, where the calcium increases. Hyperparathyroidism. And what is this calcification here? Which is more lobulated calcification that you can see, right? This is called as putty kidney, which is generally unilateral and it is seen in TB. Renal TB shows this putty kidney. Okay. So putty kidney, more lobulated calcification, generally unilateral. The kidney is shrunken in size. It is putty kidney, which is renal TB. This is not your ADPKD. The cysts do not appear white on X-ray or CT. So this is not a polycystic kidney disease. White on X-ray and CT is calcification. Right. The history that will be given in renal TB will be the history of sterile pyuria. Okay, that's an important background history there. It is history of sterile pyuria. Correct. Going to the next one. What are you seeing in this image here? Let's say this is written like after 30 minutes. This is what you are seeing on IVP. So what are you seeing here? Is this drooping, Lily? No. Correct. So look at this. First of all, the clue here is basically that it is after 30 minutes. So we have taken a delayed image on IVP and you can see this hydronephrosis on the left side. You can see the ureter on the right side. You cannot see the ureter on the left side. So there is hydronephrosis which is present, right? You cannot see the ureter here even on delayed IVP image. Okay. So what is the diagnosis? This is PUJ obstruction. There is an obstruction at the pelviureteric junction. Okay. So PUJ obstruction, the investigation of choice is IVP with delayed images to confirm that there is visualization or no visualization of ureter. And what is this investigation IVP? Yes or no? Is this investigation IVP? No. Why no? Why this is not IVP? Why? Tell me the why. Right. This is MCU and not IVP. Why? This image is MCU and not IVP. Why? Because in MCU, you are micturating cystourethrogram. So you see the cysto, the urinary bladder, and you see this urethra here, right? In IVP, do you see the urethra? No. IVP is KUB. You will see the kidney, the ureter, and the bladder. You do not see urethra in IVP. Okay? So remember that urethra is not seen in IVP. So when you are seeing urethra, it's not IVP. Okay? So remember that in IVP also you will see the contrast in the bladder. Okay? Kidney ka contrast automatically bladder mein aayega. The difference is you do not see the urethra. But when I say micturating cystourethrogram, it should show the bladder and the urethra. What are the extra things that you are seeing here? You are seeing the ureter, you are seeing the kidney. So what does that indicate? When the patient is micturating, the contrast is going into the ureter and the kidney. So what is it suggestive of? Reflux, vesico-ureteric reflux. So if on MCU, ureter is seen, kidney is seen on MCU, it is suggestive of vesico-ureteric reflux. This is not RGU. This is MCU. It is not just a urethrogram. Okay. So remember, the investigation of choice for VUR is going to be MCU. You want to see when the patient is micturating, there's a reflux happening. So remember, for VUR, it is MCU, which is the investigation of choice. Okay. And very, very important, what history do you have in VUR? There is history of recurrent UTI in a child. That's the background history that is given in vesico-ureteric reflux. That is recurrent UTI in a child. Look at the CT here. This is the pelvis, which is dilated here, filled with fluid and dilated. On CT, this is how the PUJ obstruction will look like. Okay, dilated pelvis. Classical image, what are you seeing here? Cobra head appearance. So this is the cobra head appearance of the ureter, which is dilated at the insertion. What is it called as? Ureterocele. Okay, this is ureterocele cobra head appearance. Correct. What are we seeing in the CT here? The kidneys which have come and fused in the midline, horseshoe kidney. What do you see in horseshoe kidney in the IVP? The kidney is coming towards the vertebra. The kidney is coming towards the vertebra to meet the other vertebra, right? So that is the handshake sign, shaking hand, handshake appearance, or it is also called as flower vase appearance. Okay, flower vase appearance. Is it clear with everyone? Okay. It is not that in RGU, you put the dye through the urethra into the bladder. RGU is retrograde urethrogram. You will just cannulate the urethral opening with the syringe containing contrast, and the dye will go into the urethra and some dye will go into the bladder. So you will see some contrast in the bladder in RGU. But in MCU, what do we do is we put the Foleys into the bladder itself and we fill the entire bladder with contrast so that the patient gets the urge to micturate. So in RGU, there will be only some contrast that you would see in the bladder. In MCU, it's going to be the entire bladder that's going to be filled up. And if it's a RGU, in the image, you would see the syringe containing contrast at the urethral opening as well. Telling you that we have used the syringe to put the contrast in the urethra. Okay? I hope push 37 now you are satisfied. है ना? वही. Lokesh is smart. So that was about abdominal radiology. Coming to neuroradiology. So in abdominal radiology, we have seen like the liver wala part also and the kidney wala part as well. Now coming to neuroradiology. Okay, tell me what is the diagnosis here? Important image. So what do we see here? There's a cyst with a dot inside, cyst with a dot inside. So this is neurocyst. The dot is the sarcosis, that is the scolex. Okay? So this is neurocysty sarcosis. Okay? So you would see a neurocyst with a dot appearance. Cyst with dot appearance in the brain is neurocysty sarcosis. Is this clear with everyone? What is this one here? What are the images showing? This is the dilated ventricle hydrocephalus. These are the meninges which are thick and enhancing. This is meningitis. So hydrocephalus, meningitis with those ring enhancing lesions forming a conglomerate lesion like this. Plus what investigation is this, guys? On MRI, when you see this graph, MRI image with a graph like this, it is MR spectroscopy. And in MR spectroscopy, the peak which is shown here, this is the lipid peak, right? So all these points put together, lipid peak, meningitis, hydrocephalus, conglomerate lesion, this is going to be TB. Please remember, TB shows lipid peak on MR spectroscopy. TB shows lipid peak on MR spectroscopy. Okay? Throughout calcification, do not confuse this. It was congenital toxoplasmosis, which is throughout calcification. Okay, here we are talking about T for TB. So now comes your calcification here. Where is the calcification? This is the ventricle. This is the ventricle. So what type of calcification is this here? What calcification is this? Periventricular calcification. So where do you see periventricular calcification? Where do you see periventricular calcification? Classical of, remember, V for V. Ventricle is seen with the virus. What virus? CMV. Okay. Congenital CMV shows this periventricular calcification. What encephalitis affects this lobe of the brain? What is this lobe of the brain? Surrounding the midbrain. ये कौन सा lobe होता है? Temporal lobe. So which encephalitis affects the temporal lobe commonly? Remember, it is HSV encephalitis. Herpes simplex virus affects the temporal lobe. Very, 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 very important. Okay, temporal lobe is HSV encephalitis. This one here, is it cephalhematoma or is it caput succedaneum? Is it cephalhematoma or caput? Look at this one. First of all, it is on one side. It is not crossing to the other side. Plus, there is this calcification present inside. So, it is present on one side only. Okay? And there is calcification present. This is suggestive of cephalhematoma. Okay, this is cephalhematoma rather than caput. Has been asked in the exam. Coming to musculoskeletal radiology, important images. Very, very important. What are you seeing here? The white line in the center. That is the dagger sign. Okay, the white line in the center, dagger sign. Sacroiliac joint fusion. Right? SI joint fusion, dagger sign. This is seen in ankylosing spondylitis. What HLA will you test for? HLA-B 27. Okay, HLA-B 27. What is this appearance of the skull here? This is cotton wool skull. Where do you see cotton wool skull? Remember, Paget's. Paget's has cotton wool skull. What is the appearance of the skull here? This is the hair on end or crew cut appearance. Right? This is hair on end or crew cut appearance, which is because of the increased hematopoiesis in what anemia? hemolytic anemia, the hematopoiesis increases, right? So this is hemolytic anemia, like thalassemia, like sickle cell anemia. Okay, so hair on end, also called as crew cut appearance. Okay, Paget's cotton wool, hair on end, hemolytic anemia. When you see this term sequestrum involucrum, what bone pathology are you thinking of? Sequestrum involucrum are the terminologies in chronic osteomyelitis. Okay, chronic osteomyelitis. What does the sequestrum represent? The dead bone which is sequestered inside, lying inside. So that is the dead bone. And how does the dead bone appear on X-ray on CT? It appears white. So look at this white bone in the center. That is sequestrum. Involucrum is the involuting, like healing, the new bone, the periosteal reaction which takes place, healing wala, that is the involucrum. And what is the cloaca? Cloaca anywhere means the opening. Okay, cloaca means the opening. So remember, in osteomyelitis, the bone has a very dirty appearance. Okay, right? Going to next one, is this a multiple myeloma? Is this pot spine? Is this vertebral metastasis? What is this? Pot spine. Why is this pot spine? Because remember, multiple myeloma, vertebral metastasis, they involve the bone, not the intervertebral disc. Is the intervertebral disc involved here? Yes. This is one vertebra, this is second vertebra, और उसके बीच का disc भी गया है. So this is intervertebral disc involved here, right? So remember, whenever the intervertebral disc is involved, it is TB spine, pot spine that you should think of. Okay, paradiscal involvement is the very common. So remember, this is pot spine rather than the metastasis or multiple myeloma. What endocrine condition is this? Where you see the bone which is showing the resorption, here. Yes, remember the subperiosteal resorption. Subperiosteal resorption is seen with hyperparathyroidism. There's going to be patient with history of stones, moans, groans, and bones. Right? There is bone pain, कैल्शियम के वजह से फिर रीनल स्टोन्स हो सकते हैं, एब्डोमिनल पेन हो सकता है, right? And moan, psychiatric complaints can be there. It is hyperparathyroidism. What nuclear scan do you do for hyperparathyroidism? Cystamebi scan. Very, very important, frequently asked. We do cystamebi scan. Okay, cystamebi scan is done. Going to OBGY. Right, we are towards the last phase of our session. I hope all of you are here listening and enjoying. Yes. Everybody, a quick thumbs up so that I know that you are here. Great. So tell me, what sign are you seeing here? This is what you see in a normal early intrauterine pregnancy. What sign is this? Spade-like finger is acromegaly. Spade phalanx. Okay? Remember, acro matlab distal, involving the distal phalanx. Spade phalanx is acromegaly. What sign is this that you are seeing here? Yes. This is the double bleb sign. Okay, double bleb sign. One circle, another circle. These are the two blebs. What are forming the two blebs here? One is the yolk sac, one is the amnion. Okay, the outer one that you are seeing here, this is the gestational sac. So remember, double bleb is formed by the yolk sac plus the amnion, not the gestational sac. This is seen in normal intrauterine pregnancy. What investigation is this? What sign is this? And what is the diagnosis? This is Doppler, right? Surrounding this hypoechoic area, you are seeing the ring vascularity, peripheral vascularity. This is called as ring of fire sign. Okay, this is the ring that you are seeing here, and it is seen in ectopic pregnancy. Okay, Doppler, ring of fire, and this is ectopic pregnancy. This is also Doppler. Orange color वाला भी Doppler हो सकता है, जिसको बोलते हैं power Doppler. And to give you an orientation, in the uterus, this white area is the endometrium, and you are seeing a vessel going into the endometrium. So what does that indicate? There's a polyp in the endometrium which has this feeding vessel. Okay, so this is the feeding vessel sign. Okay, this is the feeding vessel sign of endometrial polyp. Okay, feeding vessel sign, endometrial polyp, very, very important. Going to next one, right? You can see this appearance, and you are not seeing the white calvarium, frog eye sign. Okay, calvarium absent. This is anencephaly, right? Anencephaly, earliest anomaly on USG that we can identify. The management has to be MTP. Okay, MTP needs to be done here. Does folic acid supplementation treat anencephaly? अभी आप पेशेंट को बोलोगे फोलिक एसिड लो ठीक हो जाएगा? नहीं, ऐसा नहीं होगा. Folic acid prevents, folic acid does not treat neural tube defects. Okay, remember, folic acid is for prevention, it is not for treatment. Next one, the signs that you see in neural tube defects like spina bifida. What are the signs? The two signs, remember, in the two fruit wale signs, one is the lemon sign, other is the banana sign. Okay, lemon, banana in neural tube defect. Okay, so this is the lemon sign, the concavity of the frontal bone. The neural tube defect causes a pull on the brain structures and the bone becomes concave like this. Plus you have the cerebellum which becomes compressed because of all the structures coming down. So lemon sign, banana sign is seen in neural tube defect. Okay. Next one, coming to the important points in nuclear medicine and radiotherapy. LINAC. What is LINAC? LINAC is linear accelerator, which is used for radiotherapy. And what does LINAC produce? What does LINAC use basically for radiotherapy? LINAC produces, it uses X-rays and electrons. Okay, so remember, it is X-rays that are used in LINAC, linear accelerator. Acute radiation syndrome, when there is very high exposure to radiation acutely, like more than 1 gray. Okay, more than 1 to 2 gray pe hota hai. What is the first system that gets affected in acute radiation syndrome? The most sensitive is the bone marrow. So first is the hematopoietic, right? Bone marrow suppression is the first one. Last is the neurons. The CNS is going to be affected the last. Okay, first is bone marrow, then comes the GIT, CVS and the CNS. What radioisotope is used in PET scan? PET uses F18, right? Why does it use F18 only? Because it emits positron. PET stands for positron emission tomography. Okay, it's not therapy. It is positron emission tomography. So F18 is a positron emitter. Most commonly, you bind it to deoxyglucose. So it is dependent on glucose metabolism. What is the principle? Remember Warburg effect. Warburg effect is what we see in cancer cells. Okay. So remember Warburg effect, glucose metabolism, F18, all this is for PET. Previous FMG exam question, right? PSMA scan is done for what organ is PSMA scan? Yes. Very good. Remember, this is prostate specific membrane antigen. So this is done for prostate. Okay, remember PSMA is prostate specific membrane antigen. So this is done for prostate, PSMA. And system-EB is for parathyroid. What do you do for pheochromocytoma? What nuclear scan do you do for pheochromocytoma? MIBG. Okay. But if the question is what is the investigation of choice for pheochromocytoma? Pheochromocytoma, adrenal is the most common site, right? So what do you do for adrenal? There is MRI. It shows light bulb appearance on T2. So MIBG is for pheochromocytoma. Investigation of choice is MRI. Most radio resistant and most radio sensitive. Remember the cells, the tissue which is not dividing. Remember, the not dividing cells are resistant, like you have neurons. The ones which are dividing are very sensitive. So you have gonads which are very sensitive, bone marrow which is very sensitive, right? So remember, gonads, bone marrow are very, very sensitive. Neurons are resistant. What is the most resistant cell cycle phase? Cell cycle phase which is most resistant, that is the S phase. And what is the most sensitive? The cell which is actually dividing, mitosis ho raha hai. So remember G2M is going to be just give me a minute, I'll be back, just a minute. Right, sorry for that interruption. Am I audible, visible? No, resistant is S phase. Okay, right? Coming to the next one, G2M hota hai. Inverse square law. Okay, what is inverse square law? Inverse square law basically tells you the relation between the distance and the radiation intensity reaching at a point. Imagine this is a radiation source. At a distance of 1 meter, you have one person standing here. At a distance of, let's say, 3 meters, you have another person standing here. Person A, person B. So how much will be the difference in the radiation intensity that is reaching at person A and person B? So how does the distance determine that? Can someone tell me? Logically thinking, who will receive more radiation, A or B? किसके पास ज़्यादा radiation होगा? The more closer to you are to the radiation source, the more radiation you would receive. So A will receive more as compared to B. How much more A will receive as compared to B? 3 times, 6 times, 9 times, 27 times, 8 times. कितना ज़्यादा होगा? A will receive more. How much more? That is what my question is. 3 times? No. So that is what is inverse square law. Okay? When you double the distance, the radiation becomes 1 by 4. When you triple the distance, the radiation becomes 1 by 9, 3 square. When you make it 4x, the radiation becomes 1 by 16, right? So basically A will receive 9 times more as compared to B, or B will receive 1 by 9 as compared to A. Is this clear with everyone? Okay, so this is the inverse square law. As you increase the distance, the radiation decreases in relation to the square of the distance that is happening. I hope this inverse square law is clear with everyone. It tells you the relation between the radiation intensity and the distance. Okay, has been asked in one of the exams. Next one, Bragg peak is seen with. What shows Bragg peak? Very good. Remember Bragg, Br is seen with Pr, that is proton. When you use proton for radiotherapy, you would see a Bragg peak. What does that indicate is proton, when it goes into the body, it hardly gives any radiation to normal tissues. And when it reaches the targeted site, targeted tumor, suddenly there's a peak which occurs. So it gives a very, very targeted tumor targeted therapy. So that is the advantage with proton, right? Minimum damage to the surrounding tissues, everything focused on the tumor. So that is the advantage with proton beam. Okay, pencil beam like targeted therapy is possible because of the Bragg peak. Okay, because of the Bragg peak. And quickly telling you one other important point regarding what are the deterministic and stochastic side effects of radiation. Deterministic versus stochastic side effects of radiation. Remember stochastic, okay? Stochastic, CHA is CHA, it occurs by chance. That means it can occur at any radiation dose. That means, does it have any threshold? No, it does not have any threshold. But logically thinking, as the dose increases, the chance increases. Okay, the chance increases with dose, not the probability, because probability is either yes or no. Example of stochastic, C for C is like radiation induced cancer, radiation induced mutations. Okay, so cancer mutation can occur at any dose. It does not have any threshold, but as the dose increases, the chance increases, the probability increases, not the severity. Deterministic, on the other hand, means that determine. What can you determine? Threshold can be determined. Okay, so remember, deterministic means threshold can be determined, right? As the dose increases, the severity of the effect increases. So radiation induced bone marrow suppression, alopecia, cataract, skin erythema, everything else falls into deterministic. The more the dose, the more severe is the bone marrow suppression. The more the dose, the more severe is the skin erythema. So increase in dose increases the severity. It has a threshold. All other side effects, they fall into deterministic. Your cancer, mutations, these fall under stochastic hazard. Is this clear with everyone? Right? So that was about deterministic and stochastic side effects. Coming to next one, investigation before giving IV contrast. हमने देखा था KFT, kidney function test. Simple blood test is serum creatinine. What contrast is safe in renal failure? CT contrast, MRI contrast, ultrasound contrast, none of them. What contrast is safe in renal failure? CT contrast, MRI contrast, or USD contrast? Very good. Remember, USD contrast is safe in renal failure. What is the contrast that you use in USD? Contrast that we use in USD is microbubbles. Okay, microbubbles of sulfur hexafluoride gas. Remember, the gas is going to be excreted via the lungs, not via the kidney. And that is why you can do CEUS, contrast enhanced ultrasound, in renal failure. Correct? Right? This has also been asked in one of the INI-CET exams, I believe. Before doing CT in a reproductive age female, you should always ask for LMP, right? Because in pregnancy, CT scan is not done, right? It has a lot of radiation exposure. So always ask for LMP before doing CT in a reproductive age female. Practical advice, many times in our first year residency when we were new, we used to forget this. और फिर हमें डांट पड़ती थी सीनियर से, है ना? So remember, asking for LMP is important. Checking for serum creat before giving contrast is important. Checking for any predisposition for anaphylaxis, asthma, because contrast से anaphylactic reaction भी हो सकता है. So all these things we have to ask in CT, right? And also before giving contrast. ठीक है? Right? So finally we come to the end of this session, the LRR for radiology. A lot of important images, must know images, right? Must know points, concepts that we have discussed, right? So if nothing, but definitely LRR is going to help you cover up the subject. So please use LRR in a way that if there are any subjects that you have not been able to do and you want to get that confidence, okay, at least I've done something of this subject and I can expect a good strike rate out of this, then definitely, you should be doing LRR. Okay, but of course, LRR is not everything. You need to watch at least the rapid revision videos for the entire content and then supplement with PYQs, right? So that was about the today's session. I'll definitely share the annotated PDF as well. You shall get it, so don't worry on that front. Yes. Thank you so much, everyone, for so much of the great compliments and messages that I can see in the live chat, and I'll definitely share the annotated PDF. Do not worry. Right. And to all the FMG aspirants, especially, right, you have your exam coming up the first now on 17th of January. Still remember, you have good enough time to turn the tables around. It is not difficult to crack FMG. Trust me on this when I say this. Getting that 150 out of 300 is not difficult. Please don't do the mistakes that majority of the students do. That is not revising enough, just doing the notes and the videos and no MCQ practice. Being afraid of the GTs and the mock test, and so not practicing those. Please don't do these mistakes. These are the common mistakes, that I see very frequently in FMG students, and I don't want anybody of you to do that. So revision, MCQ practice, giving GTs, learning out of it, correcting your mistakes before the exam. That's all you need. And master all the PYQs. Please do the NEET PG and NEET PG at least 2 years of PYQs and INI-CET at least 1 year of PYQ along with all your FMG PYQs, right? And you shall be good to basically crack your exam. Okay. Thank you so much, everyone. And all the very best for your exam. We'll be waiting to hear from each one of you. If you have any queries, you can always reach out to us anytime. Always there to help you in your journey. Okay. Thank you, guys. Goodbye. Take care and keep studying, keep revising, and keep winning. Thank you again.